Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Welcome to today's episode of Thinking Thoracic. I'm your host, Jeff Yang, and I'm excited to be joined again here with Dr. Martin, where we're going to finish up on part 2 of her best papers in thoracic surgery. So thank you again, Dr. Martin, for sharing your list with us.
Thanks. Good to be here again, Jeff. So we finished up the lung cancer topic and screening and so forth, and now we're going to move on to part 2. So there's still some lung cancer in here, but there's going to be a bit of esophagus and other topics as well. So one of the things I've now got a routine down where I contact the editors of the Annals of Thoracic Surgery and JTCVS, and I ask them to give me metrics on what was downloaded the most, what's been cited the most, what's sort of gotten the most attention in the last couple of years. And so they've been great about sending me spreadsheets with all kinds of metrics. And unfortunately, we don't have time to go through each of these papers, but I think they're papers you ought to all look at, see if you either want to read them, use them for a journal club, or what have you. So I'm hoping the listeners all will have access to our list of papers or slide decks so that they can see these in more detail. But there are several expert consensus and guidelines types of papers that are listed here as being either top cited or top used or downloaded. One of the papers that hit these metrics was one we discussed in the last session, one that looks at the lung cancer screening eligibility of patients with lung cancer. And then there's also a paper about robotic lung transplant that got a lot of attention too. So I'd encourage you to go through these papers again separately. We just don't have time to discuss each one of them individually. And then JTCVS gives me first a sort of top cited list and then a top downloaded list. So they're a little bit different. And there's a couple of papers about esophageal squamous cancer that got a lot of citations, looking at various combinations of treatments. Also treatment patterns and clinical outcomes of resectable lung cancer getting immunochemotherapy. This is real world data. And then single port robotic surgery, 100 cases first reported, and then high-risk features in recurrence in stage 1 lung cancer. Those were top cited, and that goes back, usually we have to go back 2 years to get that because it's too hard to get citations that just got published the month before. And then for top viewed, I'm going to highlight one particular paper here, but again, there's quite a few expert consensus documents on this list here for subsolid nodules, donor lung procurement, time from diagnosis to resection intervals, and prehab. And then also there's a paper about the Z poem, the Zenker's diverticulum endoscopic approach. But the paper that I reviewed in more detail, I'll talk about was, is there long-term consequences of doing a thymectomy? And we might think, well, no, we've been taking thymus glands out forever and ever as part of a heart operation, or we do it for myasthenia gravis or thymoma. What is the big deal? But there was a paper that had come out, I think 2 years or so ago. Oh, yes, it was 2023 in New England Journal. And I think it's from Dr. Yang's institution, but not from any surgeons at Dr. Yang's institution, that talked about some long-term health consequences of getting rid of the thymus gland. And I think there was a lot of lay population that was very nervous about that. There was a lot of discussion in the press. So a couple of thoracic surgeons said, hey, let's look at this from our viewpoint. So Frank Detterpeck led this effort, and he looked at thymectomy patients, or he just sort of reanalyzed the way that trial was done. and looked at it a lot more closely and looked at maybe some collinearity between some of the variables that they were comparing. And the original study had compared thymectomy for, by itself versus thymectomy, just cardiac surgery. So sort of having an open heart operation, and looked at the association of thymectomy with survival and cancer risk. And that, with increasing age, there's also increasing cancer risk. And so there's some collinearity there, autoimmune diseases, infections, all sorts of things. But essentially, the take home from this was that attributing the results of thymectomy to all of these different outcomes was really probably not scientifically correct, and that more research is needed to be done to be able to say that there's some detrimental effect of removing the thymus gland. So it was a way of just sort of systematically re-looking at the data that was presented that got so much interest in New England Journal. So I think this is definitely a great journal club paper and one that's worth reading more about and thinking more about. I personally wonder how often the thymus gland is disrupted, devascularized, or removed during cardiac surgery. So is that really the appropriate control? So there's a lot of room for discussion here. So the next topic I moved on to was various cancer surveillance strategies. And there was a couple of remarkable papers on this topic this year. This is, I will tell you, a really hard area to study because it's hard to really rigorously have a follow-up schedule that everybody follows to the letter. So follow-up tests often get done at all different times. It's supposed to be 4 months or 6 months. And how do you categorize that? So there's some inherent difficulties in studying this area, just as a background. But the trial I wanted to first point out was called the SUPER trial. This was published in the Journal of Thoracic Oncology in 2025. And it looked at the use of PET for surveillance after lung cancer treatment. And I'm sure you all get a lot of questions about, well, shouldn't I get a PET scan for follow-up instead of a CT? Isn't it better? And this was a rigorous way of looking at that. So this was PET scans for stage 1 to 3 lung cancer patients after curative treatment. So many cases that's resection. Sometimes it was other versions of treatment like chemoradiation. Multi-center randomized controlled trial out of Europe. And they randomized patients 1-to-1 to either PET or a standard contrast enhanced chest CT for surveillance. And they looked at the proportion of recurrences that were subsequently treated with curative intent. And what they found was that there were about 22% of patients had a recurrence, and it was identical that got curative treatment as a result of those tests in both groups. There were more recurrences found in the PET group than the CT scan group by 90% versus 77%, but there wasn't really a meaningful difference in time to recurrence and no difference in overall survival. So their conclusion was just that the PET didn't help us find things that needed intervention that led to curative intent treatment. So doing that more expensive, higher radiation dose test did not pay off. So I'm glad that there's a modern study to look at that because I think this is a question that comes up a lot. And then another paper that I think is worth knowing about was, again, controversial. This was a letter to the New England Journal of Medicine in May of 2025 saying that routine cancer surveillance across the board, not just thoracic cancer, does it help or harm patients? So it's a letter, and they have this table up that shows studies on cancer surveillance in breast, colorectal, lung, and sarcoma. The lung paper they quote was from 2010. So I think we have to bear that in mind. That's really outdated. And they basically said that that it just doesn't help, that there, it doesn't change survival, that the surveillance cohorts died at even a higher rate maybe than the non-surveillance cohorts, and that it just doesn't help. And so we shouldn't do it. I think we all could argue very differently about this, that there's patients that absolutely live and die by their CT scans and they want to know what's happening. There's also a component of patients that get really anxious and nervous every time it's time for their screening, and we should think about that. But the conclusions of these authors was that these provide short-term recurrence surveillance tests, provide short-term reassurance for patients, but that surveillance doesn't necessarily improve their well-being, and that there's no evidence to support that it improves their well-being. And I thought this would be a great TSOG or Thorn trial to do in the future, to look at quality of life and sort of patient-reported outcomes around this, because I think we might find really interesting information from that.
Yeah, I think that makes a lot of sense. The paper that they cited for lung, like you said, Dr. Martin, was from 2010, and there's been so many more new developments that have happened before that, since then. So that I think that could be a really great project for the future.
Right. I mean, just to put it in simple terms, 15 years ago, if we detected a recurrence, our interventions were limited. We could give platinum-based chemotherapy, which we now know does not have a very big impact. Now we've got targeted agents, we've got focused radiation, we've got immunotherapy, we have all these things that actually work. And so doing the surveillance and finding the recurrence, we can do something about it, whereas before we really couldn't. So, okay, we're going to switch to esophagus. So kind of go through this a little bit more briefly, but there's a paper. I'm not going to go through the details of it, but it's a really good paper to read. And this is the AATS expert consensus document on surgical management of esophageal cancer. This was led by Daniela Molina and by a great panel of experts from around the world, most of them surgeons, but also other specialists in esophageal cancer. And it's everything from T1A all the way to locally advanced and histology specific guidelines when we might consider organ preservation. So it's a really great document. I'd say something that's a must read for any of us who do esophageal cancer work. Matterhorn is another trial, hopefully is not a new name to any of you, but it just came out a few months back at ASCO in June of 2025. There's been 2 publications from it. The first one was a New England Journal paper in July 2025 looking at event-free survival. And then there's been a more recent publication with overall survival data, or maybe that was even abstract form only, but this was a randomized trial for adenocarcinomas of the gastric and GE junction locations. It's a global study taking a flat type of regimen and adding durvalumab before and after. And what they found was a significant difference in pathologic complete response, 19% when durva was added compared to 7% with flat alone. And of interest, I think if you look at geographic region, non-Asian populations had even more impact than in Asian populations. And then tumor location at the GE junction as opposed to the stomach was also more impactful because about a third of the patients in this trial were GE junction and the rest were gastric. So I think, again, reading this paper, we want to look at the areas that are sort of focused on thoracic surgeons. So, and then overall survival was presented at ESMO, and I guess that's just abstract form so far, but that did show a significant difference in overall survival at 24 months with a hazard ratio of 0.78. So I think many of us have already adopted this as our standard practice for esophageal adenocarcinoma. If you haven't yet, it's definitely worth talking with your multidisciplinary team about it because I think this is rapidly becoming the standard of care. The Sano trial is another big one that got a lot of interest and attention, and that finally came out last spring. This is looking at an organ preservation strategy where patients get whatever neoadjuvant therapy, typically chemoradiation. I think that was required in this particular study. And if it looked like they had a complete response, and we never know for sure, we have a PET scan that looks negative. We have an endoscopy that looks negative. So for all intents and purposes, we can't find residual disease. And you took those patients and some of them didn't go on to surgery and some of them did. And it looked at how often we could preserve the organ. And in that case of clinical complete response, which maybe happens 15 or 20% of the time, about a third of those patients were able to avoid esophagectomy and still go on to surgery later. Now, there's a really good commentary about this because there's some concerns about the exact trial design. And that was published in Diseases of the Esophagus. I've got it in the slide deck from some worldwide leaders who just point out some of the limitations of the trial and how it's not so easy to adopt that right away. And then Checkmate 577, this kind of passed by without a lot of fanfare, but I'd been really anxious to see the overall survival of Checkmate 577. This is the strategy of chemoradiation, esophagectomy, and then adjuvant nivolumab. And it showed a really big disease-free benefit. And so we all expected it to show an overall survival benefit. What it turned out statistically, it did not. And that was also from ASCO of 2025. Numerically, the overall survival was better, 51 months versus 35 months. But when it came to the statistics, that was a non-significant difference. So it's, again, a paper worth reading through and looking at the nuances. There's probably some real difference between PDL1 scores that might help you stratify who's going to benefit from this and who isn't. And this is, of course, a different strategy than FLOT plus Durva. So it's, again, something you'll have to discuss on a case-by-case basis, but important to realize that that overall survival came out and it was not positive. And then another really important trial is looking at pyloroplasty. This is a randomized trial, I think just coming out in print now, but was online in the fall of 2025, led by the Pittsburgh team, and looking at in any interventions on the pylorus in minimally invasive esophagectomy. Do you need to do it? And so they were looking at endpoints of pneumonia or anastomotic leak, with the idea that if your stomach doesn't empty, you either are going to aspirate or your conduit blows out and you could leak. So they randomized 143 patients. It's sort of an interesting randomization scheme. So it ends up with 90 getting a pyloroplasty and 44 not getting it. And they stopped early because the criteria were met, with many fewer events in the pyloroplasty group, 18% compared to 27%. So provocative, something I think if you do esophagectomies, you're going to want to be familiar with that data. Similarly, staging laparoscopy and GE junctional cancers is an area that I think we probably don't pay as much attention to as we should. There's 2 papers on this topic. There's on diagnostic laparoscopy, and one of them says there's not really much of a difference, maybe a 5% that are upstaged if you take all comers that have GE junctional cancers. And then the other paper that came from Memorial Sloan Kettering, they kind of focused in on signet ring cell patients. And if there's signet ring histology, then there really is a more concerted benefit there. Maybe 20% of the time you're going to find occult or visible metastases at diagnostic lab with signet ring cell histology. So in looking at both of those papers, that was my take home, that my signet ring patients, I probably ought to be doing this, and I hadn't been in the past. So the next topic we have is on benign esophagus. And there's one paper I wanted to highlight here. This is looking at a very large series of Heller myotomies for achalasia. It comes from the Cleveland Clinic group, and they looked at over 1,000 patients, longitudinal follow-up for Heller myotomy for achalasia. And I think the really key point here, that's another question we often have, patients ask us, we kind of wonder, if someone shows up in our office with achalasia, how likely are they going to be to get an esophagectomy at some point? And it's 3%, which is better than what I thought it was. And they show that overall people actually do quite well with Heller myotomies, and that the likely of additional interventions is low, but a lot of times the first intervention may take things in a better direction after a Heller myotomy. So, they just had really robust follow-up to be able to answer these questions. Many of us don't have the ability to do that follow-up, or the patients that are interested in doing it. And so it talks about, again, some of the reintervention strategies that are out there, and that with those strategies, we can get by without having to go to esophagectomy in the vast majority of patients. So another great journal club paper to do. And then lastly, there's a couple of surgical professional issues that I thought were really relevant to our practice. One is a great paper I came across about delivering news of intraoperative death. And that's a situation none of us ever want to be in. And if and when it happens, we're often sort of woefully underprepared on how to handle it. We're so distressed ourselves that it's good to have a playbook to go by that you can look at if this happens and kind of give yourself some framework to follow. And this came from the Wellness Committee of AATS. And it came out, I can't remember exactly when it's published, but in the last couple of months of 2025. And essentially they reviewed the literature and put together their collective wisdom and experience to come up with some guidelines that talk about how to set the stage at the very beginning of your interactions with patients and families. But then while things are going on in the OR, if they aren't going well and it looks like the patient may not survive the operation, how do you use your OR team to help start to lay some groundwork? How do you go out and talk to the patients? What do you say? What do you not say? And just, again, some really helpful guidelines and then also sort of how to handle it after the fact. How do you heal yourself after an event like this? So we did this as a journal club at UVA, and I made sure our cardiac surgery colleagues were there too, because I think they have a lot of experience and wisdom in this area. And it was probably one of the most sort of raw journal clubs we've had in a long time. And then the last paper I have is from Annals of Surgery. And this is about cases getting canceled or postponed, something we all hate having happen, and how does it vary by surgeon or patient sex? And this is a study out of Canada, Alberta, Canada. And they went through all sorts of things of how often a case is bumped or postponed. And they looked at, again, all these different variables, the gender of the patient, the gender of the surgeon, types of surgeons, et cetera. And they found that when they adjusted for all kinds of things, female surgeons were more often bumped than male surgeons at an adjusted odds ratio of 1.21. But there was no difference in postponements because of overbooking by gender. So their take-home message was, yes, there's a difference here, and this can actually make a difference in productivity and how many RVUs we can do. Because if you get bumped more often because of your gender, that's going to affect your productivity, and the people who are making those decisions should take that into account. And then there's a couple of videos that I think are worth watching. Another one on the professionalism topic is a great presentation from Ross Camage, who is a lung cancer oncologist. And he himself became a lung cancer patient, and he talks about his experience with that and really, really important lessons in there about how we relay messages, how we explain things, what it's like to be on the other side, what each step of that journey feels like when you're on the receiving end. And then also a great CTS-NET video that has to do with sublobar resection and lobectomy. Very controversial, and that's from Joel Dunning, November 26th, and that's been watched a whole lot. Really good video to watch. So in our slide deck, we have some podcasts that are worth listening to, including Thinking Thoracic, and lists of all these papers, so if you want to look them up yourself. But thanks for sticking with us this long, and Jeff, thanks again for the invitation this year. I really appreciate it.
Great. Thank you so much, Dr. Martin. I know this is, again, a true tour de force, covering papers all the way from general cancer to lung cancer epidemiology and screening, to perioperative care, to lung cancer, esophageal cancer, surveillance, benign esophagus, and these really important professional topics. So really appreciate it and look forward to having you back again next year.
Great. Thank you.
To our amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.